Great. Hi, everyone. Welcome to the People AMR Network webinar. It's great to see so many of you on the call this morning, and we've got more and more people joining. Just to let everyone know that we are recording this call, so if you don't want to be recorded, please keep your camera off. And a recording of the webinar will be available on our People AMR Network webpage in the future. So I'm really pleased to have 4 speakers with us today. So thank you very much to those 4 speakers for taking their time to come and speak to us. They're going to be talking about the PRUDENCE trial, which is a very large international European trial that was conducted over a number of European countries that was exploring a point of care test strategy for reducing antibiotic prescribing for acute respiratory infections. And we've got 4 speakers today because we're going to be both talking about the details of the trial as well as the details of the process evaluation. So I will start by handing over to Emma, who was the trial manager for PRUDENCE. Thank you, Emma.
Thank you. Thanks, Sarah. Okay, can everyone see the slideshow? Okay.
Yes, all good, Emma.
Oh, good, great, thank you. Okay, thank you, Sarah. My name's Emma. I was the trial manager for the PRUDENCE trial. So I'll be kicking off the presentation today and just describing the background of the trial, giving you an introduction to the trial and the methods, and then I'll present the headline results, and then I'll hand over to Chris to talk about the results in more detail. And then Marta and Sybil will talk about the process evaluation. The introduction, so has the slide moved on? Sorry, I think there's a slight technical hitch. Can you see the introduction slide?
No, I can't.
Not
okay,
yet.
Sorry, I'm having some problems. Sorry, just bear with me. I'll try that again. Sorry, everyone. Okay, sorry. Is that visible? The slideshow, is that coming up?
Yes.
Yeah.
Yeah, we've seen it in. There you go. It's moving.
Okay,
too.
great. Sorry about that. Okay, so as I mentioned, I'll give you a bit of an introduction to the trial, go through the background and the methods, and then Chris will go into the results in more detail. So the PRUDENCE trial was a pragmatic platform randomized controlled trial looking at point of care diagnostics for acute RTI in community care in Europe. So we had 2 different settings in the trial. We had primary care and long-term care. The vast majority of the patients came from primary care settings as intended. We had about 10% of the patients came from long-term care facilities. Primary care sites we had in 10 different countries, and the long-term care sites in 5 different countries. So the recruitment took place over more or less a 2-year period from the end of 2021 to the beginning of January 2024. The background to the trial, so the reason why we did it, obviously, as we all know, AMR is a major concern, a major public health concern worldwide. Very simply, we need to either reduce the amount of antibiotics we're using, or use the current ones more efficiently, or invent more. So one thing that could potentially help is to use point of care diagnostic tests. So particularly in community care where most antibiotics are prescribed. The idea is that these will help target the antibiotics to the patients that will benefit the most from them. The aim of the PRUDENCE trial was to assess the effectiveness and cost effectiveness of a point of care testing strategy for RTIs in primary care in Europe. So we wanted to assess whether the point of care testing reduces the amount of antibiotic prescribing without compromising patient recovery. So obviously we don't want the reduction in prescribing to come at the expense of patient outcomes. So we had two primary outcomes in the PRUDENCE trial. The first one, we were looking at the proportion of patients being prescribed an antibiotic over 28 days. And the second co-primary outcome was the patient reported time to return to usual daily activities, so their time to recovery, essentially. One of the sub-aims of the PRUDENCE trial was the nested mixed methods process evaluation. So Sybil and Marta will talk about this in more detail later. So we performed interviews and questionnaires with patients and clinicians. So we wanted to capture their views on the point of care tests and identify factors that influence their use. So barriers to their uptake and facilitators to their adoption. We also had a biomarker sub-study. So we were looking at microbiology biomarkers in blood samples, nasopharyngeal swabs and stool samples from a subset of patients. We haven't got any results from this sub-study yet, unfortunately, so we can't present any of that today, but hopefully soon we'll have some results from this sub-study. So we were looking at the effect of antibiotics on microbiomes and ideally hoping to develop biomarker profiles to distinguish between different etiologies. Moving on now to the methods. So the population, the trial participants, it was a very broad age range. We had patients from 1 year up. The patients were presenting with symptoms of either lower respiratory tract infection or upper respiratory tract infection or both. And we asked that the GP had either decided to prescribe an antibiotic or was considering prescribing an antibiotic to that patient. As I mentioned before, we recruited from primary care practices in 10 different countries and long-term care facilities in 5 different countries. And we followed the patients up for 28 days. So we asked them to complete a diary every day for 14 days, either online or a paper diary. And we gave them a phone call at 14 days and 28 days to ask a minimal set of questions. So the intervention in PRUDENCE was a point of care testing strategy. So we were comparing patients managed using the point of care testing strategy to patients receiving just usual care. The tests that we used in PRUDENCE were the CRP test that was measured using the Abbott Affinion analyzer. And we also had the Group A strep test and flu A and B test using the BD Veritor analyzer. So the patients, different patients received different tests, and the test that they received depended on their COVID status, whether or not flu season was in swing, and what the patient's predominant symptom was. So this was decided by an algorithm, and this was performed by the database in the background. So it was very simple, quick and easy for the clinicians to use, and they just typed in the answers to 3 questions, and then the database told them which test or which tests to perform on the patients. So one very important thing to note, we did provide guidelines on how to interpret the test results, but we did not mandate the course of action. So the clinician was free to decide their course of action using their own clinical judgment and using their national guidelines, of course, based on the results of the test. The per country recruitment, some countries only recruited to long-term care in the long-term care settings. So about 10% of patients were from long-term care. The top recruiters were Georgia, the UK, and Greece. So moving on now to the results. We just as a reminder, the first co-primary outcome was the proportion of patients being prescribed at least one antibiotic course over 28 days. And our hypothesis here was that this would be lower in the intervention group compared to usual care. And in fact, the study was powered to detect a 15% difference. What we actually saw was this. So as you can see, it was a very, very similar amount being prescribed. The amount of patients being prescribed an antibiotic was very similar in both groups. So there was a very slight reduction in the intervention group, 1.3% reduction. But crucially, there was no statistical difference between the two groups regarding the proportion of antibiotics prescribed. The second co-primary outcome was the time to return to usual daily activities. Our hypothesis here was that this would be the same in both groups. And in fact, this is what we saw. So the two curves you can see are virtually identical. The median time to recovery, median time to return to usual daily activities in both groups was 4 days. And again, there was no statistical difference between the two groups. The secondary outcomes in PRUDENCE, we had quite a few. So for example, a class of antibiotic, whether the prescribing was delayed or immediate, various other secondary outcomes, and again, no statistical difference between the two groups. So at this point, I'll pass over to Chris to just go into some of the exploratory analyses and just explain some of the results. Thank you. Thank you, Chris.
So, question, where have the slides gone?
Oh, sorry. Marta, Marta, do you want to share your slides and give control to Chris? Thank you.
Hi, everyone. While we're sorting out the slides, it's Chris Butler here, and I was the co-chief investigator of the trial. Just going to sort of make a quick comment here on some of the, shall we say, design issues and some of the sort of things that might help us understand these results. So we looked post hoc at the proportion who were prescribed antibiotics split by the clinician's prior probability of them prescribing an antibiotic. So you can see from this slide that when there was already a high chance in the clinician's mind, they already decided definitely going to prescribe antibiotics. In fact, it kind of there was more prescribing in the usual care group. So in other words, the difference was there was a reduction, not dramatic reduction, but there was a reduction in those where there was a high and medium likelihood of antibiotics being prescribed. And curiously, amongst those where they said they were less likely to prescribe, this is before any testing, we found that the people who were tested got more antibiotics. So kind of interesting finding, overall zero difference. But in those who were tested, slightly fewer antibiotics prescribed in the higher likelihood group, but more antibiotics in the lower prescribing group. So that's interesting. Now, let's see if I can move on. Marta, can you maybe move it on because it's not moving on when I move it on? Thanks. Yeah, so that just puts it in statistical terms. Next one. Yeah, so just to sort of say a little bit about what, a fantastic acronym in my view, But prudence is one of the 5 virtues, I think, or was it 4 virtues? And there's a picture of prudence with the mirror reflecting self-awareness, the snake, which is the ancient symbol of wisdom, and the arrow, which is the strength of purpose. And using those aspects of prudence, I want to kind of look into why this finding came across and surprised us so much. Because I tell you, it took our breath away when we saw the results. This is not what we were expecting. If you can get on to the next slide, Marta, that'd be good. Okay, so some questions. Why did we come up with overall a big fat zero? So people say, well, did you include the right patients? As Emma pointed out, we included people for whom the clinician felt after the assessment they were likely or had already decided to prescribe antibiotics. And I think that is right. It's different from other studies where all comers were included of point of care tests because where you aren't going to prescribe antibiotics, you've got a low probability of prescribing. What's the point of testing? It is in those who you are planning to prescribe where a test might help you reduce the prescribing proportions. So I think that was the right thing to do for our inclusion. Now, some people say, well, there's a learning effect here, there's contamination. So should we rather have done a cluster randomized rather than individually randomized trial? So we had large numbers, we had good power for the study on an individually randomized basis. There might have been a little bit of contamination or learning effects after having done the test, but we don't think that was a lot. And that risk, I think, was lower than the problem inherent in cluster randomized trials where you can't fully account for baseline differences between your clusters. Practices are different and kind of seeing the outcomes for patients in different practices or different countries as similar to start off with is a difficult one. Now, people say, well, we gave the clinicians the test kits and advice on what the results meant, and perhaps we were not rigorous or intensive enough in our training. But in a way, that's what most other trials did. And our question really was relevant to that. If clinicians get access to the testing kit, are they, what happens when you buy these things? You get the test kit, you get the advice on what to do. So it was a kind of a real world evaluation of what we might do in any case. And these were experienced clinicians who were already, I think, pretty good in communication skills training. So some people say, well, these hapless clinicians, they didn't do what the test told them to do. Now, the trouble with that is in a directive approach that you have to be absolutely certain that the test is telling you to do the right thing and is not going to harm the patients. And there isn't sufficient evidence, in my view, for a directive approach based on these tests. And next slide. Just to quickly think about questions. Sackett and Haynes have identified 4 phases of diagnostic research. And I'll just focus on phase 3 and phase 4. So the phase 3 question is, does the test distinguish patients with and without the target disorder amongst patients in whom it is currently reasonable to suspect that disease is present? So does it tell you who shouldn't be treated? And then finally, phase 4 is if you do test patients, does that improve their outcomes compared to those who are not tested? Next slide. So we basically had the hypothesis that if patients are exposed to, are the patients exposed to point-of-care testing safely prescribed antibiotics less often than those who are managed without testing? And that's a reasonable question, but it is also perhaps reasonable to ask, does following the non-antibiotic management implications of the test reliably predict equivalent patient recovery and rule out no disasters? Because, no one wants to take a chance that that 1 in 100 or 1 in 1,000 patient, that test tells you don't give them antibiotics, then they go on to die. No clinician wants to have that. Okay, next slide. So there are 4 or 5 stages of looking at why test results might not have the effect that you want. In our case, all the patients that were allocated to the test basically got the test. The machine mostly gave them the right result. The clinician thought about it, management was decided, but that management didn't always follow when it came to treatment implication, the results of the test. Next one. And I was interested in looking at results from a previous study we did, that if you looked at C-reactive protein, although the sensitivity and specificity, negative predictive values are incredibly high, if we looked at those with a C-reactive protein test of less than 20, still 3% of them had pneumonia. And if things go wrong in 3%, that isn't sufficiently predictive to reassure clinicians that in every case they should follow the test result. Next slide. And here's a study from South Africa where you had very, very good performing test result for tuberculosis, that the clinicians, in fact, just basically, it made no difference to their practice having this incredibly impressive point-of-care diagnostic, because they knew that the test was occasionally wrong, and that their clinical assessment was good enough. Next one. So just to introduce the concept of reliably predicting comparable outcomes, given the test suggests no antibiotic and the risks of getting it wrong. And this comes from important papers that I encourage colleagues to look at by Poka and Kasira. And here you can see the group of patients who you should test depending on how reliably the test rules out bad things happening if the test gets it wrong, if you see what I mean. So the test accuracy in predicting no benefit from antibiotics without harming patients is something that we just don't know of. And in determining who should be tested and the confidence clinicians will have in following the test result, it needs to have that information, which I don't think we had at the time. Next slide. So revealing my incredibly skilled talent here in PowerPoint, I thought about the trial design in 2 ways. We answered the phase 4 question. What happens if you test people? What happens if you don't? And if you randomize everybody to either get the test or not, you're comparing all the outcomes for those who had the point of care test and those usual care, and you look at the proportion who got antibiotics and the recovery. And so that's fair enough. That's what we did. But maybe we should have done a phase 3 question. Next slide. And that is to test everybody. Those with a high CRP or positive strep test, treat them. Leave them out of the trial from then on. I mean, you follow them up and see what happens. Those where the test suggests that there's safe management without antibiotics, just randomize those to get the antibiotics or not, and then see whether not treating people with that test that suggests you shouldn't treat them recover at the same rate. And that, I think, is where, with all these POCTs, we do not have sufficient information. But I'm really looking forward to the qualitative researchers now taking up that baton to unwrap the reasons what the patients and the clinicians told us about these results.
Thank you, Chris. So we will focus now on process evaluation. So as Chris was saying, in addition to looking around effectiveness of point-of-care strategy in the trial, we also set out to do a process evaluation with the aim to examine how the intervention produced or hasn't produced its effect. So now the qualitative research is becoming increasingly recognized for the value of bringing additional insights in the trial, and we specifically look at things like mechanism of impact and implementation and context to make sense of the trial results. So as Emma have highlighted, we had 4 components to process evaluation, the mixed methods process evaluation, and these included interviews with clinicians and patients and surveys as well. So I'm not going to focus much about the clinician and patient surveys in this talk, just for the sake of time, but we will go a little bit deeper with the semi-structured interviews results of the 6 countries which have taken part in the process evaluation. So we have selectively recruited these countries to make sure that we've got diversity in healthcare systems, prescribing rates, and geography. And these were the UK, Belgium and Germany, Ireland, Georgia, and Greece. So just to highlight some of the things which we felt might be useful in making sense of the results which Emma and Chris have highlighted. So we have done 32 interviews with clinicians from across these 6 countries with variety of experiences levels, but most of them, as Chris was saying, experienced clinicians. So let's think about in what kind of scenarios point-of-care tests provided perceived value. So the first scenario is that the clinicians felt that point-of-care tests reduced clinical uncertainty. And the cases where they particularly highlighted that behavior were, first of all, where the patient's discomfort and distress was quite high, or at least perceived one. Secondly, where they have come up with non-specific symptoms, for example, fever, or when the bacterial and viral presentations of symptom was quite similar, so they were not sure. Secondly, and that's also very important for us, there were instances where clinicians felt that the intention to prescribe changed dramatically after they have received after they received the point-of-care test results. But of importance here is that this happened in both directions. So both for clinicians who initially decided to prescribe, they changed to not prescribing, but also from clinicians who initially decided to not prescribe to prescribing. So really showing that mindset that test result could act as this crucial part of evidence for them to decide. Then the third case where it provided value was not necessarily to reduce uncertainty, but provide reassurance. So it was basically a confidence booster of making sure that, yes, I've made the right decision. The test confirms what I thought, and it's basically giving you a kind of a pat on the back saying, this is the right direction I have decided in the first place. And the fourth tool in which the point-of-care test was perceived as valuable was as a tool to convince the patient that this was the antibiotic was not needed. And this was especially the case for patients who might have started antibiotics at home in countries when it was possible, or who felt that antibiotics prescribing was kind of a default position when you're presenting with RTI. However, in contrast to all of that, we have also seen that clinicians felt that in what was perceived as a textbook version of symptoms, so imagine kind of a pass on the tonsils, inflamed tonsils, they felt that this was the scenario where the test results would have also sometimes limited value, and they felt that they should just follow their clinical presentation. Related to that, but not necessarily the same, it's about the trust in clinical's knowledge and experience. This is about thinking, well, actually, I've been treating patients for many years. I've seen this before. I know what's happening here. But also this kind of sometimes rapid assessments, the eyeballing of patients and thinking, well, this is what I think that is happening in this situation before the test results was revealed. What is also important to think about is this perceived accuracy of the tests. So while initially there were no concerns or perceived concerns around the accuracy of the tests, if there was this kind of clinical or cognitive dissonance that the test showed this, but I felt this, some clinicians felt that over time, this meant that basically tests was not accurate. So they might have over time relied less and less on the test results to guide their decision making. And finally, I think that also shows nuance to decision making is also that the timing of presentation. So there were instances where the clinicians felt, well, actually, no, if the patient presents too early, we have to think about that, and maybe the symptoms are not showing up in the test results yet. Equally, patient might be presenting quite late in the illness, so the test is not detecting this either. So it's really showing kind of that they have been considering this very carefully of how the test can influence or not influence them. And finally, also, I think it shows that in some cases, despite that for some clinicians, the test was perceived as a useful communication tool, for some, it also shown that even with this test, they felt unable to convince the patient that the antibiotic was not needed. And this was, as I was saying before, that the patient may have started antibiotic course. So then we are having a very different conversation in a consultation around stopping these antibiotics based on the test result. Now, just moving on to the patient interviews. So we've done 56 interviews, again, across these 6 countries. And the sampling here was important in terms of the age of the patient, but more importantly, in terms of the type of test they have received and whether they have received antibiotics or not. So you can see here that around half of patients receive antibiotics and the rest hasn't. So that was important for us to think about that. So I know that a lot of people on this call would know, but I think our study also confirmed that people do come or have come to the GP to seek reassurance because they were worried about the symptoms. They needed advice. They needed someone to look at them, and or for in some countries also about the sick note. But the idea was that they have engaged in self-care, and I have come to the GP or other practitioner to get kind of further help. So what are patients saying about the test? So the first of all, they are saying that, well, if they really wanted antibiotic and they got it, they felt that the position and the value of that test was quite profound. So they felt that the test in a kind of inverted comma helped them to get antibiotic, because otherwise they might have relied on the subjective clinical experience. So they are seeing that as a kind of bringing additional evidence which then they can use to get antibiotic which they wanted. However, I think, and that is also important to highlight, is that we also have patients who are very cautious around antibiotic use, and they saw the value of point of care tests by giving them precision in actually knowing if the prescription is important or not, and that was in both directions. So they basically were saying, well, I don't think we should be getting antibiotics unnecessarily. And it's very good that clinicians now have access to this information so they can make more informed decisions. And finally, also, when it comes to the value, we have seen, similarly to clinicians, that the patients felt that it could change their minds. So the patients who came with the idea that actually, I really want antibiotic here, they felt that actually this test convinced me that I don't need it. You can clearly see it, and therefore it also may have impact on a kind of more long-term seeking behavior. However, similarly to what I was discussing when it came to clinician, patients similarly talked about kind of the limited power of point of care tests when it comes to the symptoms they perceived as severe and basically the antibiotics. So if they were, felt really unwell and that was communicated to clinicians, they felt that basically point of care tests is not relevant here because clearly they are in need of something stronger like antibiotics. This is interesting, I think, because obviously patients were not saying that, I'm coming too early, I'm coming too late, but they were picking up on a discourse from clinicians who I think basically were verbalizing their thoughts when they were examining them. And then they kind of pick up this kind of messages and they brought them up to the interviews as well. So that was something about, importance of communicating the test results and how patients receive this information and how this may affect their help-seeking behavior in the future. And then again, thinking about the social factors, as I was saying before, some patients were convinced, some patients were still not convinced after their test result. So it was really showing that this kind of cultural beliefs around antibiotic necessity are very important to think about from both patient and clinician perspective. So in summary, before I hand over to Sibyl to think about the implications, what we've seen from the clinicians' interviews, and if you think about the top table, if you think about the likely behavior change, it is possible that the point of care test may bring about the behavior change if there's uncertainty, if there isn't a need to convince the patients, or if they basically have that mindset, I'm going to use this point of care test as a main evidence for prescribing or not. And the final thing which we've put as a support is that, this is kind of confirming what I thought as opposed to leading the behavior change in any way. But equally, if you think about the temporal considerations, the uncertainty, the accuracy concerns, that all is showing the work we have to do to make sure that the point of care tests are taken into account as well. And then just a summary of patient views. Again, we have seen very positive value when it comes to giving the kind of perceived objectivity to the process, and also thinking about aligning the views, but also the same concerns as clinicians when it comes to perhaps not following the advice of the test. So I'm going to hand over to Sibyl now, and I will move the slides for you, Sibyl, and over to you.
Okay, thank you very much, Marta. I'd like to spend the next 5 minutes discussing the implications of our process evaluation findings and what they could mean for approaching point of care testing in antimicrobial stewardship. So let's start with the striking disconnect that in a lot of national and international policy documents, one of the key strategies for reducing antibiotic prescribing is point of care testing. So the assumption is straightforward: implementing point of care testing will reduce prescriptions. However, the PRUDENCE trial showed something different, that when we gave clinicians access to point of care testing for respiratory tract infections, we saw no clear reduction in antibiotic prescribing, specifically in the consultations where clinicians were already considering or had plans to prescribe an antibiotic. So we have this gap between policy expectation and trial reality. So our process evaluation explains why this happened, and also importantly, what we need to do different in the future in implementation. So as Marta has illustrated, our qualitative findings show that point of care tests did have value in specific scenarios. So particularly when presentations were ambiguous, when there was genuine diagnostic uncertainty, or when viral and bacterial symptoms overlapped. But I think here is a critical issue. So we found that clinicians need to perceive uncertainty to find the test valuable. And this matters because an 18-country audit study found that in nearly 90% of the consultations, healthcare professionals are confident in their no prescribing decisions. So if clinicians rarely perceive uncertainty, then selective point of care test becomes limited by design. So the test can only influence decisions where clinicians are open to being influenced. And this might not happen very often in routine practice. And even there are also systematic barriers, as we have seen before. So next slide, please. So as we have seen, test results don't operate in a vacuum. So they're interpreted through multiple clinical, cognitive, and social filters. And any of those can reduce the test influence on the final prescribing decisions. So this really brings us to our core implications, which challenges the current thinking about point of care testing. So point of care testing alone as a standalone technical solution has limited impact. They are necessary, but they are not sufficient. So really, to enhance the contribution to antibiotic stewardship, point of care tests need to be supported by complementary interventions that target the broader behavioral context of prescribing. So this isn't about whether point of care tests works, it's really about creating the conditions in which they can work. So next slide. So what does this really mean practically? So we propose 4 complementary intervention strategies, and importantly, we already have evidence that some of these really work well. So first of all, we have the communication skills training, and we've seen from previous trials, also like from the GRACE intro study, that enhancing communication skill training combined with patients' information booklets enhances clinicians' confidence in addressing antibiotic expectations. It equips them with practical responses and consultation tools. Second, enhanced point of care training. So not just the mechanics of using the test, so the technical skills in using the test, but also building trust through understanding test accuracy, timing considerations, and how to interpret the results confidently. Also, we need strategies to address cognitive dissonance. So really helping clinicians reconcile test results with their clinical experiences, even when presentation seems like textbook cases. So this doesn't always mean changing prescribing. It also means ensuring all available evidence to inform the decision. And fourth, and very important as well, is the context-specific implementation. So funding models, consultation length, workforce capacity, workflows, these aren't just afterthoughts. They're essential considerations that will vary by setting. So in each European setting, the workflows might be different, and they need to be addressed for successful implementation. So this points us toward clear research and implementation priorities. So future research needs to evaluate multifaceted interventions that combine point of care testing with behavioral support strategies. And implementation efforts must integrate point of care tests with supportive systems, not deploy them as isolated tools. And done rightly, this approach can enhance point of care testing's contribution to antibiotic stewardship, but it requires to think beyond the technology itself. Thank you very much.
I will hand over to Chris now for the final slide. Thank you, Chris.
Thank you. So in summary, with this PRUDENCE trial, I think it's a massive achievement, really. And you know, we did this trial throughout, partly during COVID and beyond. So we had an amazing consortium led by Herman Goossens with many partners. And we managed to set up the collaboration, win the funding, design the trial, and implement it in 14 countries, which is no small ask. And in a way, we strengthen primary care and long-term care facilities, the research reputation of these sites as a way as a place for doing research. And we brought on new teams, and we consolidated the existing networks that we'd been working with for a long time. And we did answer an important question in a very rigorous way. It was a phase 4 research question, as I mentioned, and that is, are patients with respiratory tract infections managed with the addition of point of care tests in primary care, where the healthcare professional is considering has decided to prescribe an antibiotic, prescribe few antibiotics without impacting on recovery? And we answered that question. We found actually that the tests do change prescribing behavior, but probably not definitely not as we predicted. And, the increase in prescribing, where there was a lower likelihood of prescribing antibiotics, sort of counterbalanced the decrease in the higher probability group. So the findings surprised us a lot, and that's important because you shouldn't, if you know the answer, you shouldn't do the research. There's a lot more to come, really, and I'm particularly interested in those issues around therapeutic thresholds and the accuracy of the test in predicting good outcomes when no antibiotics are needed according to the test. I think that a lot of the research that is going on at the moment around implementation studies of these point of care tests are premature, and that we need more of that phase 3 type research that I identified. But most importantly, I think, and I think the qualitative research has been like gold dust throughout of this, that there's no such thing as a negative trial. The information that has come from both the quantitative and the qualitative research here has been really important. And understanding of take the field far further forward than I could have imagined. And in terms of implementation, there's gold dust in every aspect of this research. So thank you very much. And I think we've got some time for questions, Marta.
Thanks ever so much. That was a really great talk, all four of you. Yeah, before we hand over questions, I'd just like to say thank you. It was a really great way to explain a complicated, very large trial and extensive process evaluation. So the results from both are really interesting, and also the reflections that you each made along the way are really nice and useful to think about as well. So if anyone does have questions, please raise your hand or put them in the chat if you would prefer to type it. I might start while other people are thinking, and I'd go to Sybil. Oh, George, I'll hand over to you, George.
Thank you, and thank you for the presentation. I was interested in whether the group felt that there was a difference in what has been published, for example, in the Welsh group, with a reduction in prescribing because of looking at a different clinical group, where it was pharmacists compared to general practitioners, and about how they then used and followed that test. And I also wondered, I'm sorry if I missed it, about a difference between prescribing practice for lower respiratory tract and upper respiratory tract infections, and how clinicians might use that. Thank you.
Do you want to kick off, Marta, about the Welsh thing?
Well, I think maybe it's better to come from clinician, but I suppose from our perspective, we know that some clinician groups are more likely to follow the protocol, and I think that might be one of the mechanisms through which the effectiveness of the tests was different according to the context. I think also we are talking about huge heterogeneity in terms of the countries. Well, now we haven't been powered to explore cross-country differences, but we are talking about different healthcare systems, different length of consultations, different prescribing rates as a baseline. So I think that there are lots of factors which may play into kind of understanding why in some contexts it has been effective and in some hasn't. Not to mention why people, as you say, presenting. So COPD is very different to cough and colds. But I think Chris may add some more, maybe from clinical perspective.
Yeah, I think medically qualified, experienced GPs are more inclined to follow their clinical judgment rather than follow a guideline, in a sense. And, you know, they often criticize being notoriously bad for not following the guideline in every case. But in a way, that's why they are there, because their clinical stuff should override guidance, which it's not mandated, it's guidance. So sometimes we find that different professional groups are better at following directive approaches to responding to test results. Now, we also previously done a trial, it's called a PACE trial in COPD, where we did find actually dramatic reductions in antibiotic prescribing without harming patients as a result of CRP testing. And I think the reason why we found those dramatic results there is that people really know that in acute exacerbations of COPD, chronic obstructive airways disease, it is a minority where you can find any evidence of a bacterial infection. It's often air pollution or viruses that trigger these things. And if you've got a really low CRP, I think it is pretty good at ruling out benefit from antibiotics. And so where there is that ambivalence, you get the additional information of a low CRP, and that gives you confidence to rule it out, because in a sense that's a believable thing. And that evidence is I think stronger in that context. So is more likely to give people confidence to following a non-antibiotic prescription in that context. Tristan wants to come in. Oh, yeah.
Yeah, hi, thank you. Tristan Clark, infectious diseases physician from Southampton in the UK. Thank you very much for that, Chris. Excellent work, and I think it's incredibly valuable to all of us that work in the point of care field. I was a bit late to the call, and I apologize.
Have we lost Tristan?
Yeah.
Oh, he's just frozen.
I think he's frozen.
Oh.
Sorry about that. I think I left the call briefly there. Can you hear me?
Yes, we can hear you now.
Yeah, now I can't hear you guys.
You carry on talking, Tristan.
But thanks, Chris. Yeah, so the question was about the platform use, and in particular the time that it was taking to get the results back, because previous work has suggested that the longer the turnaround time, the longer the time to result, the less likely it is to impact decision making. So I just wanted to know if you, which platform you used and how quickly you were getting the results back in the trial. Over.
Well, I think we used the sort of lateral flow test for not lateral flow test. We used for Abbott. We used the CRP machine. I think it might have been the Finian, but I can't quite remember. But it was. So that's a fantastic thing, and I did it myself. Sits on the desk, nice machine. Light goes on. Get a drop of blood in there. It makes a noise, but it takes a matter of minutes. So with the patient sitting in the room, they can see sometimes, sometimes you can ask the nurse to do it, but often the patient saw the whole process, the drop of blood going into the device and getting you the result within a few minutes. And then the Becton Dickinson result, I think, was available within 15 minutes. And so that was also pretty quick. Marta?
Well, yeah, just to complement what Chris was saying. So I think what we also have found is that different practices across different countries have implemented different workflows to accommodate that. So that's one thing. And the second thing, which I think is very important, is that the sequence of doing that test. So for example, are you taking history, then a test, and then clinical examination, or what is the order of these three activities? And that may send you in particular direction, which then difficult is to back away from. That's one thing. And the second thing, which is even more nuanced, is that if you verbalize any of that to the patient, for example, I'm thinking that I'm going in that direction while you're waiting for a test, then that also may impact how the conversation goes in terms of confirming or providing contrasting results. So I really believe that you make a very important point about not only the time, but also what is happening in that time while we are waiting.
Great, thank you. Can we go to Amrit?
Sorry if this is, sorry, Amrit, FETP Fellow, UKHSA. Sorry if this is a silly question, I don't know much about point of care tests, but could a lot of these findings be explained by limitations with the point of care test because it's only, I guess in my head I was like, oh, it's going to differentiate between viral and bacterial. That would be so helpful. And actually it's very much more narrow than that.
Yeah. I'm itching to jump in at this point. Sarah, could I open the batting on this one? So look, yeah, I think just to say in general that tests distinguishing between or claiming to distinguishing between virus and bacteria that's kind of last century type thinking in my view. The etiology doesn't make a huge amount of difference to your well, it influences your decision making, but there's a machine that will give you 20 different types of viruses now at the point of care. But why? Why do you want to know whether it's a virus or a bacteria? Well, the implication is that if it's a virus, don't treat it with an antibiotic. And if it's a bacteria, then you should. But there's a lot of times where you find a bacteria in the back of somebody's throat, a group B hemolytic strep, that is just minding its own business and enjoying a little moment there, chilling in your pharynx, and then you get a virus, you find the strep, and then you start thinking, oh well, now what do I do now? So you get that problem, and we saw this that. People where they weren't thinking of prescribing antibiotics actually did prescribe in some cases. And could that have been because they unexpectedly found a strep there that could have been a bystander? Now, on the other hand, there are other kinds of strep that the point of care test won't identify, which can be pretty nasty, and the clinicians know this. So if they're looking down the throat and it looks like a dog, and it's barking like a dog, and it's wagging its tail like a dog, and the strep test says negative, actually, are you going to believe that? Because the test isn't accurate enough to override your clinical assessment, and we saw that in some of the qualitative studies. So I think the problem is if you're thinking about well, let's have a test distinguishing from a virus from bacteria. If it's a bacteria, treat. If it's a virus, don't. Well, firstly, they're antivirals that you might want to use in some cases. And secondly, there are many cases where the test isn't suggesting bacterial infection, but it could be. And there are many cases where the test isn't ruling out isn't properly ruling in the test. So we need to think more about how well does the test predict benefit from antibiotics and safety in not prescribing antibiotics for this particular patient.
Thank you, Chris. I think we've got one more clinical question in the chat, which is actually from Kuhn. I don't know if you've read it, Chris. So regarding the paper you cited with 3% under 20 milligrams from CRP having evidence of radiographic pneumonia. Some Dutch colleagues say that low CRP and radiographic pneumonia more likely means viral pneumonia than bacterial pneumonia. So they would still feel confident to not prescribe if there are no clear signs that the patients had bacterial pneumonia. So are they, in your perception, not risk averse enough?
That's a point. What I'm getting at here with that kind of South Africa where the gene got overridden clinician.
Sorry, Chris, I think your audio's gone. You're suddenly breaking up a little bit.
Let me see. No, bugger. Perhaps go on to George.
Okay, it's a bit better now. But anyway, yes, George, we'll get your question in last. You've got 1 minute left.
Thank you. Just very quickly, I was wondering, and apologies if I missed, about presenting what would have happened if they had actually followed the test result, as opposed to making their own clinical judgment. And I think there's lots of different spin-offs of this. It's interesting, you mentioned about what would happen if low likelihood and why they were doing the test if there was low likelihood, lots of things. But yeah, did you do, and present if I missed it, what would have happened if they'd followed the test result?
Can you hear me or not?
Yes.
Yeah.
Yeah. There would have been, so if in every case that they had followed the implications of the test result, there would have been substantial reductions in the proportion prescribed antibiotics. I think that's clear. Yeah.
Okay.
Wonderful.
Yeah, and perhaps if you're hearing me, just to follow up from Koen's thing, what he's saying is correct, that a low CRP in the face of radiographic pneumonia does suggest a viral pneumonia. But I still think that if you were to say to a clinician, the patient's got pneumonia, the test says we don't need to treat, you're happy with that? They might say, well, I'll take that into account, but I won't necessarily follow the test result every time. So I think we go back to the point that different pneumonia comes in many different shapes and sizes, as does every other condition. And if you miss a serious pneumonia, and you can have a low CRP in a serious pneumonia, then that's not a nice thing. So we are still needing evidence that even if patients have pneumonia and a low CRP, and you don't prescribe them antibiotics, that everything's going to be okay. Now, I think that's the point that I'm really trying to hammer home here, that we need the outcome evidence that following the implications of these tests really does result in effective reductions of antibiotics, but critically important, safe reductions. And we're not going to land up harming, yes, really, but harming seriously, harming patients. But I think, just one last comment, I think perhaps the thing that we're most proud of with this study is the richness of the combination of the trial design, the quantitative aspects and findings, the implementation in all those countries over all those years, but combined with the social science perspectives, putting the voices of the clinicians and the patients center stage to help us understand and make sense and take the field forward. So it's a wonderful synergy between disciplines here, I think, that I hope will have massive policy impact along the lines that Sybil has mentioned.
That's wonderful. Thank you, Chris, and thank you, Sybil and Emma and Marta as well. We'll leave it there for today. These papers are under review, so we'll hopefully see them in print soon, so everyone can look out for those. And please join us for our next webinar. Chika, can you remind us when our next webinar is, please?
2nd of December at 11 o'clock. So look forward to have everybody join that as well. Thank you so much for joining for this session.
Thank you very much, Chika. Lovely to see everyone online. Thank you. Bye-bye.